We are all very proud of our firefighters and EMTs. We ask them to go into very stressful situations and perform their duties with a very high level of competence. Our guest tonight will tell us about the toll that can take on some of our emergency responders and explain a program that's been created to help them. To my immediate right is Dr. Suzy Gulliver. She's the director and chief of the Warrior Research Institute with BaylorScott&White Health. A native of Massachusetts, she holds a psychobiology degree from Quinnipiac College. I was practicing that over and over, Quinnipiac College.
You got it right.
And I got it right. And a master's in clinical psychology from Connecticut College. She completed her PhD in clinical psychology at the University of Vermont. She spent 12 years with the VA Boston healthcare system. She came to Texas in 2007 to serve as director of the VA VISN 17 Center of Excellence in Waco. She founded the Warriors Research Institute in 2013. And to her right is Dr. Elizabeth, or Lizzie Coe. She joined the Warriors Research Institute earlier this year as a postdoctoral fellow. She earned her doctorate in clinical psychology from Baylor University. She has completed clinical practice at the Baylor Psychology Clinic, Talitha Koom, say that for me. Did I say it right?
You got it right. Yeah,
Talitha Koom Institute, like I knew it all along, and the Methodist Children's Home. Ladies, take it away. I'm excited to learn about this program.
Well, we're delighted to be here today. We've come here to talk with you about Project Access. And the objective of Project Access is to improve behavioral health for firefighters and paramedics by developing a telehealth clinic that provides protocol-driven, evidence-based treatment for firefighters with behavioral health needs.
There are 4 phases to Project Access. We are currently in the 4th phase. So to tell you a bit about where we've been, phase 1 was to adapt the unified protocol for the transdiagnostic treatment of emotional disorders for firefighters, and to adapt that for delivery via telehealth. Another part of phase 1 was to develop a firefighter cultural awareness training for clinicians so that they would understand a little bit more about firefighter culture. Phase 2 was to gather feedback on that cultural awareness training that we developed from a group of firefighters, and also to pilot test that training with a group of PsyD students from Baylor University.
Phase 3 was to pilot the telehealth clinic with 5 separate firefighters, which we've completed. Through that piloting phase, we really were focusing on working out the techno glitches that happen when you're doing telehealth. We refined our procedures a little bit, and now in phase 4, which is the phase we're in currently, we are open for business, delivering free mental health treatment that's evidence-based and state-of-the-art to firefighters throughout the entire state of Texas.
The funding for Project Access was provided by a fire prevention and safety grant from FEMA.
So why we set out to do this particular project, we became aware of a need for more clinicians that had some deep knowledge about firefighter culture. Many of the firefighters that I've spoken with over the years have talked about how frustrating it is when you go forward to ask for help and you have to educate the clinician on what it means to be a firefighter. So we recognized this problem and developed a cultural awareness training with our fellow firefighters who are part of our research team. We also were aware that there are so many barriers to reaching out and asking for help, especially for our emergency responders. And we thought that having culturally sensitive clinicians who were delivering the care on a telemental health platform where firefighters didn't risk a loss of anonymity by coming to a business or a place of business to receive treatment. The other reason that we decided to jump into this project with both feet was that the mission of our research institute is to educate future generations of healthcare providers. So people at the practicum level, people at the pre-doctoral level, and people at the postdoctoral level are getting exposure to the firefighter culture and also being trained in how to deliver these evidence-based practices.
So some kind of background information on behavioral health in fire service, things that we found from our research. 1 in 5 firefighters will have some kind of behavioral health issue, and about 56% of career firefighters and 45% of volunteer firefighters reported binge drinking within the past month. So that is one particular area of behavioral health where there are commonly issues. And we also know that PTSD affects 24.2% of firefighters. So those are just a couple examples of the types of behavioral health issues that people in fire service may face.
So, and to underscore that, these behavioral health issues tap into and expand upon physical health issues. We're very aware that cancer is a growing concern in our emergency responders, and binge drinking is linked to inflated rates of cancer. So we're very concerned with the whole firefighter and reuniting them with wellness. I mentioned before that there were barriers. Specific barriers for firefighters are the lack of culturally aware clinicians, a fear of breach of confidentiality. One of our early surveys showed that this was number 2 or 3 on the list of reasons that people didn't ask for help. A big problem in asking for help is stigma, and stigma seems to continue to be alive and well, although declining for behavioral health issues in fire service. And then finally, a belief that our treatments aren't actually treatments or that they don't work. We now have decades of research that shows that we can reduce behavioral health suffering in people reliably. Maybe not to zero, maybe not to absolutely pain-free, but we can help people move from a place of illness to a place of wellness with the treatments that work. And those are the treatments we deliver, particularly the unified protocol.
Mm-hmm. So some other points about access to treatment specifically for firefighters. 68% of firefighters report that they would not recommend the behavioral health services that are provided to them through their department. So even though there's some access that is provided by departments to these types of services, there's a good portion of firefighters who would not recommend those services. So we're hoping that we can provide some other avenues for that. And along with that, although EAP programs are available for firefighters, they are rarely used. So there is a need for some other access points to these services.
So telehealth. Telehealth is defined as the use of digital information and communication technologies, such as computers or mobile devices, to access healthcare services remotely and to manage your healthcare through those services. Telehealth aids in the alleviation of stigma. Your care comes right into your home or right into your phone in your vehicle, and so you're not in a public place asking for help. It also brings greater access to folks who are in rural environments where there may be neither providers nor that sense of confidentiality. And one of the most exciting things, and the thing that converted me to being a believer in telehealth, is that a series of studies by the VA demonstrated that the outcomes for mental health care received via telehealth are as good as the outcomes for face-to-face treatment. And on top of that, people are as likely to stay in treatment to get the full dose when they're in the telehealth environment as to when they're face-to-face. And they're also reporting the same level of satisfaction with the treatment. So that's really hitting all the high points of what would make a provider enthusiastic about a telehealth platform. And that's where this project went.
So to talk a bit more in depth about the specific treatment that we're providing through Project Access, that treatment is called the Unified Protocol, or the UP for short, and it combines some mindfulness work, cognitive therapy as well as behavioral therapy to teach our patients and participants new ways to respond to uncomfortable emotions. And we use emotions broadly here. That would include things like anger, depression, anxiety, emotions that are part of the trauma response or the stress response. We teach our patients new ways to respond to those emotions, which reduces symptoms of many different types of mental health disorders.
To back up a little bit, that clinician cultural awareness training that we referenced early on in this presentation, so this was developed with input from retired and current firefighters as well as licensed clinicians. So we convened a group of people who have worked in behavioral health with fire service that were EAP providers, were peer counselors, and were licensed clinicians. And we had them develop a training that is, it takes about 90 minutes to deliver this training. It is delivered actually by a peer support specialist from Boston Fire and myself, and now is a standing curriculum that we can share with other departments. Anybody who comes to work for me in the WRI receives this cultural awareness training, and they have ongoing supervision about how to be culturally aware. So when someone bumps into something new in the course of working with a firefighter, they have seasoned clinicians and seasoned firefighters that can clarify or educate around any areas of confusion. So we found this in our most recent work with this. We tested it with 35 peer support counselors of the IAFF, and they were very positive that the training as it stands now would be useful to clinicians in home departments throughout the United States and Canada.
So to tell you kind of where we are with Project Access at this point, there are 3 study therapists on our team. I am one of them. We have 2 other trainees. We currently have 14 firefighters actively in treatment, and about 4 more who are in that screening and consent process. And as of today, there have been 51 total treatment sessions provided.
So if you're interested in participating, let me outline for you what the participation process looks like. First off, at the end of this presentation, you'll have all our contact information, and you would reach out through that contact information to find out what steps need to be taken. There is a brief screening to make sure that you're eligible for the treatment, and then you complete a consent form that you send back in to us. We do a thorough pre-assessment so that your clinician knows the nature of the problems that you're trying to grapple with. And then we put you into a weekly psychotherapy session that occurs via WebEx. The therapists are very flexible about working around your work schedule because they know it's not the typical 9 to 5. And midway through treatment, we do a quick checkpoint to make sure that everything's on track, and we have you do an assessment at 6 weeks. We have you do another assessment at 12 weeks. And then after you've finished all your sessions, we ask that you complete a 1-month follow-up session. That 1-month follow-up session serves 2 purposes. One, it gives you a check-in so that you have a final contact with us to make sure that you've held on to all your treatment gains. It also allows us to evaluate what we need to do differently to make the therapy stronger for people in the future. If it's necessary that people get additional treatment, we facilitate that, but in typical outcomes with the Unified Protocol, we see most people wrapping up treatment at about 12 sessions. So those are the step-by-step things that happen when people come to us for treatment.
Here's our contact information. As we've been saying, the study is up and running. We're ready for more participants. We'd love to get the word out to as many people as possible. There are lots of ways to reach us. You can call us. We do have a 24-hour study phone line, so you will reach someone at any time of day on any day. We also have an email. You can reach out to us in that way, as well as a website where you can go and read more about this project as well as some of our other projects. And we are also on Twitter now, so if you are on that, give us a follow.
So these are a list of the references because I am a clinician first and a scientist second. And as a scientist, you always make sure that you cite your sources. I understand that this program is available to you after hours if you want to double check my references for everything we've said in this little introductory discussion of Project Access. And those 10 references should help you find your way around. And this is our flyer, which is downloadable, I understand, from Clay and Company, that you can print this out if you'd like to post it anywhere that you might work or any place that you think it might be useful. And now I think we open to questions, right?
Absolutely. Thank you guys so much for this program, as well as coming on and talking to us about it tonight. We do have some time for some questions for the good doctors here, so let me reiterate once again how to get those to us. You can reach us by phone at 512-251-8101. You can fax us in your questions if you so please at 512-251-8152. Interestingly, the faxes come over the internet now. That's an interesting thing.
Yes.
You can email us at safed@texas.net, SAFED@texas.net. Texas is spelled out. If you've ever had to email safety, you probably have that already saved in your email application. Or you can text me right here. In fact, we already have one, 512-567-0857. Normal text messaging rates do apply there, or may apply there. And please don't call that number because I can't help you over this phone. Let's start off with some of these text message questions that we've got in. Okay, this question has a lot of acronyms that I don't know. Hopefully, maybe you guys do. Does the treatment include EMDR, PET, and CPT for PTSD? If not, what specific protocols are used?
Okay, so the Unified Protocol is a protocol unto itself, and it was written about. It was actually a treatment protocol that I helped develop when I was working with Dr. David Barlow in Boston. And we modified the Barlow protocol to fit fire service culture. So with our collaborators in Boston and the people on our team, we made sure that the language that's in the protocol maps onto the culture. We do not do, in this particular treatment program, we do not do EMDR, we do not do prolonged exposure, and we do not do cognitive processing therapy, which are the three protocols that are written about in the text. And the purpose of not doing those three other protocols is twofold. The first is that the Unified Protocol is a transdiagnostic protocol, so it goes across all diagnoses, and we wanted first and foremost to provide a generalist kind of treatment that would be applicable to any problem that a firefighter might call in for, right? And CPT and prolonged exposure and EMDR are most often implicated, although they treat other conditions, they're most often implicated in the treatment of PTSD. But because there are other more prevalent diseases that people struggle with in fire service, we wanted a more general approach. And that's why we selected for this first project, the Unified Protocol.
So while PTSD is a huge factor for a lot of firefighters, you wanted something that could be applicable across, like you said, cross diagnoses, and so not just folks with PTSD, but possibly other issues.
Exactly.
And this, I think this text came from someone with a behavioral health background or something like that, because I'm like, wow, that's a lot of intense inside knowledge there.
Treatment acronyms.
Treatment acronyms, yes.
Yes.
Is there a charge for the service?
No.
Nope.
Free of cost.
free of charge.
Thank
Excellent.
you, FEMA.
Thank you,
Thank
FEMA. Exactly.
Thank you,
Thanks to
FEMA.
our funding source. Yes.
There you go. Oh wow, this is a long text, so bear with me through this one. And I haven't screened it, so I'm not sure all of what it says. Do you correlate isolation to any of our symptoms as firefighters? A lot of isolated dorm rooms are being installed in fire stations now, thus making family time in the firehouse a rarity. Peer-to-peer relationship is important after a traumatic call. When these new firefighters run off to their rooms and get their electronics and close the door, it's very difficult to address issues with any kind of first line of defense, CISD.
It's a very good question and a very complicated question because there are so many things in there. So yes, there is a correlation between social isolation and the development of symptoms after a traumatic call. The correlation is not from firefighters specifically. That's a general statement about people who are exposed to traumatic stressors, like soldiers or disaster survivors, some of whom may be firefighters, but it's not there isn't a body of research that's specific to fire service in this question. The second question is an interesting political question, right? The private bedrooms in fire stations is a new development in fire stations throughout the U.S. and Canada, and is hotly contested with resources, etc. Isolation into electronics is a age related variable, and so the final part of that question is whether after a bad call, if firefighters retreat from each other, does that make their likelihood of developing symptoms greater, right? And then there was a throw in on CISD. So CISD stands for Critical Incident Stress Debriefing.
Which is after, like the text said, a big call, a critical incident, so to speak. You come in and debrief to deal with the stress, right? I mean, I'm just extrapolating from the acronym that I just learned.
Yeah.
So, all right.
So that and so the CISD model is one tool in a toolbox, right? It's one thing to do on the heels of a bad call. But the field is moving towards, just as, at the outset they moved towards physical fitness, we're moving towards behavioral fitness, so that there are other kinds of prevention in addition to CISD that can be useful. So having a peer support team who checks in on people irrespective of what's happening on calls, having a peer support team who gathers around and encourages the active duty members to engage in good self-care, or lets people know about changes in benefits, or lets people know about new threats. So in addition to peer support and CISD, I think that the final part of that question about isolation is a very important question. And when we observe one or two firefighters pulling away and changing from being interactive and connected to isolating, that is a red flag. And just like any other situation, when you see a big behavioral change in someone, you should at least ask, are you doing okay?
Excellent. So this next one, okay. Who will you refer, okay, I see what they're saying. Who will you refer to for PTSD? This is actually the same questioner who asked the EMDR PET. I guess the concern is you get someone in that telehealth program who clearly you could diagnose with PTSD. Is there a referral service? And maybe not even just for PTSD, but like anything that you can make a diagnosis and you think this needs to go beyond telehealth.
So the Unified Protocol does have preliminary data that says it treats PTSD.
Okay.
And those data are growing. And there are more and more people using transdiagnostic treatments for PTSD. So there is an evidence base for it. if someone were in acute need of additional treatment, we have connections throughout the state of Texas to help get them to additional treatment.
That's another question we had come in. Is this suitable for a crisis situation? If the firefighter enters into a crisis, now this isn't currently something like a helpline where you can just pick up the phone and call, right? You've got to go be through the screening program and get into accepted.
Although that's not a long period of time,
right.
So people can be in acute distress, and as long as they're safe for themselves and for the people around them, then we can get them into treatment in a matter of days.
Okay.
And so that protocol is the same as the VA used when they started to roll out telemental health, and the same as other telemental health agencies around the country are doing.
How much of this have you seen? You mentioned the VA. Have you seen a sort of this used with soldiers, and is it based
actually,
off of that?
It's got a wonderful history within the VA. So the National Center for PTSD had a branch in the Pacific Islands, and it's just untenable to get all the veterans that live in those islands to evidence-based care. You'd have to get them on airplanes, right? So they were a natural experimental place to pilot these evidence-based treatments in the telemental health platform. So that's what they did. And what they found was that their outcomes were just as good as face-to-face outcomes. Not only that, but there are some veterans who are in situations in which you can't actually safely bring them in to the hospital environment, and that they're actually better treated with a little bit of distance. That doesn't apply to firefighters, but it's an interesting, different way of thinking about it. So the VA led the way on whether it was safe and whether it had the same outcome and whether it was satisfactory to people with PTSD in establishing that telemental health works.
Excellent. Let me go to another sheet that I've been given. This question's kind of interesting. How did the project come into being? You talked about actually how you created it, but what was the sort of impetus for creating?
That's a great. So it's on multiple levels. One thing is that when I do get a call, and because of some of the work that I do nationally and internationally, I get calls from all over the place. My brother, my sister, my kid, my mother, my father is in crisis and we need to get them to treatment. Can you help me? And it takes what feels to me like an inordinate amount of time for me to find those resources. And you don't want someone who maybe has been sitting on symptoms for years and finally they're willing, and you can't connect them to somebody good who really knows their stuff. So that frustration, and that was shared by a number of the people in our group, led us to write this grant. And we were lucky because it was funded, and now here we are. And we're establishing it for Texas, but our hope is that this would be a living treatment entity for firefighters in Texas, and that it will pave the way for emergency responders in other states.
So that kind of leads me to the next. I'm going to combine two questions here. One that came in was, how many firefighters can your program serve at one time? And another question that we got during the program was how do you scale this program? You said, Lizzie, you're one of 3 current therapists, and you've currently got 14 in treatment right now. If I know anything about the fire industry, we've got probably a lot more than 14 that need help and could take advantage of this kind of program. What are are there plans to scale wider? You said hopefully nationally. Where are we going with that?
You're asking two big dreamers.
Yes, well, and that's what I want to hear. I want to hear the big dreams. They don't have to necessarily, what is the
Map onto
hope?
reality.
Yeah.
So I would say, that I consider for each of our therapists a full caseload between 20 and 30 active people weekly.
Okay.
Okay, but remember that they don't all start on go, like day one, because we don't have wait lists right now.
Right.
So to answer the first part of the question, that's what we're looking for, where our therapists are not full right now. We also have 2 additional licenses that could provide more treatment if we got to the wait list kind of situation. So I'm thinking that we could be managing on the order of, our additional license is part-time. So we could be managing on the order of 80 clients a week right for this first funding period.
Okay.
Okay? In the future, we would hire more professionals and more students to see more patients if there were an established need. And that's part of what the first year of this project is to determine, is just how much need there is. We staffed it to begin with 2 therapists, and now we're thinking that we might need more.
So you mentioned when you talk about getting new therapists, you talked about, and I thought that was really key, about the culture sort of, what did you call it? The word for it was, when you're introducing them, you did a training basically, right? A 90-minute training. Is that something that, and Lizzie, maybe you can answer this as one who's taken the training to be introduced to the firefighter culture and how important that is. Do you keep up with that kind of thing, or is there? Because I imagine the 90-minute training is effective to get you into the world of firefighting and into that industry, and have you learn a little bit about what they go through. But as you go, do you immerse yourself more in that?
Very much so. Yeah, that training is a good intro. Our team is kind of doing trainings on an ongoing basis. One of the things that comes to mind for me, maybe because I lead it, is our science meeting, which is every week on Friday. We look at the latest literature. We often look at the latest literature on firefighters and emergency response personnel to see kind of what are the latest findings in terms of treatments and things that are being done to help. So we really make an effort to stay up to date and really immerse ourselves in that world. Also, on Tuesday afternoons, we have our FEMA meeting, which is a combination of, meaning no disrespect to us, but eggheads like us, and then senior firefighters. We have Captain Frank Lito, who is from New York City Fire. He's on the phone with us every week. We have Lieutenant Willie Ostagai, retired from Boston Fire. We have Brian Nee from Boston Fire. And then we also call in locally folks throughout Texas who are involved in fire. So they interact. We're interacting with fire service as collaborators and colleagues weekly. And all of the people who are in training at the WRI are expected to participate in that meeting as well.
Okay.
So they're getting those sorts of exposures. We've been asked to do some critical incident work with a fire service, and Lizzie will probably participate in that with me, and then also with peer trainings. Michelle Pennington, who's our program manager, will be presenting at the IAFF's ALTS conference in California. So she gets plunked down in the middle of firefighter conventions regularly, which is another exposure.
And I hope it's okay that I share this too, but on our team we have some personal connections to fire service as well. So
that's true.
I think we try to keep as many touch points as we can to emergency response.
That's right.
Yeah, this a text came in while we were talking about, sort of the kind of things we're talking about here, like maybe visiting different stations across the to get a feel for, because a firefighter in a large department like Houston FD is going to have a very different experience than a and I'm sure you guys know this, I'm just saying this just to get it out there, but a VFD in rural East Texas or rural West Texas is going to have a very different experience than an Austin firefighter or Houston firefighter and everywhere in between. I mean, we have our saying, if you've seen one ESD, you've seen one ESD. Well, you can say the same in some cases with fire department. I mean, it's the same, but it's very different sometimes. Yeah. And so do you find yourself trying to expose yourself to the large range of different departments and different experiences that firefighters have?
That's part of the plan. One of the struggles with the clinician awareness is waiting for the opportunities to come to do a station visit. We get invited, and I always say yes when we're invited, and then who gets to go is dependent on their clinical load and that sort of thing.
Sure.
But yeah, it's not ivory tower kind of stuff.
You're going
it's full immersion.
Stuff.
Yeah.
That's great.
Yeah. And I would kind of add on to that a quick shout out to our participants in the study so far, who kind of come in knowing that we're trained and we want to help in this way, but they're also, knowingly signing up for a research study. They want to help as well. They want to contribute so that clinicians like myself and like our team can do better in the future.
Right. And so we have more clinicians who are actually trained in this, which is part of why, people will say, well, I don't want to participate in a study because it'll be students. Well, the reality is that those students will hopefully grow into being clinicians in your communities.
Possibly specialize in this.
Specialize in this field.
Yeah. I'm going to paraphrase a question here, but have you seen sort of any difference in the level diagnostically between volunteer and paid professional firefighters? Has that ever come up?
That's a tough question. The literature says that there are higher rates of some conditions in volunteer than in professional departments, but that may be a sampling bias, right? Because volunteer departments have very different resources around them than paid departments do.
Sure.
So, you depending on where you're volunteering, you may, be putting your full-time job at risk by volunteering on your local fire department. And that's a different equation than it being your full-time job with a full cadre of benefits. So we don't have great data on it, but we do have some survey data that indicates that there are higher rates of different mental health problems in volunteer departments than in paid departments.
Yeah, I never really thought about that, but if somebody's volunteering and they're not a professional firefighter, that's a whole different interesting amount of stress. I say interesting, I don't mean that like oh, that's interesting. I mean that's really kind of interesting to study. Like there's a different amount of stress coming in someone who has a full-time other job and is just working as a volunteer, and could affect their mental health differently.
Right. When I was a third grader, a classmate in the rural town I was raised in, her dad fell off the volunteer truck on the way to a call and broke his leg, rendering him unable to go to his work where he was paid. And his wife, my friend's mother, was furious about it, right? Furious about it. And so, there's just anecdotal evidence, right? But from the time I was pretty young, I was gathering data about how these job choices affect people's health and well-being in the community.
And your program is open to volunteers
all
as well as paid firefighters.
Yes. Again, thank you, FEMA.
Yes.
Yeah. Okay, so this question is asking, Oh, I see. What signals? So say you're a senior official, senior fire official, which sometimes in command staff they need help too. But in this instance, we're talking about command staff looking at their firefighters. What are there any signals that might you could recommend that they look into a mental health resource
For the people they supervise?
Yes.
So there is a measure that our team has been involved in developing that's a good sort of litmus test. It's called the Sources of Occupational Stress. And when people see their scores on that measure going up, it's just 14 items. So you could self-administer that and say, it's worse this quarter than it was last quarter. This might be a time to reach out to peer support, or this might be a time to have a behavioral health educational thing. So that's one thing that leaders could look at. Another thing that leaders could look at is when you get a working group that is clearly not working, and not in the way of pointing fingers at individuals in that working group, but that's another litmus test. When there's a crew that used to do pretty well together that's not doing well together anymore, that's a good litmus test. And then finally, just the major life stressors, when people have deaths, divorces, bankruptcies, addictions, those are all huge flags. Anything?
Yeah. Well, you mentioned it earlier, but just anytime there's a marked change from how you know a person to typically be, if you notice a change, better to check in than to let something slide that was really important.
Yeah. What was the biggest issue in the pilot program? You talked about technical glitches. Was there anything lesson learned that really defined a change in the program, or was it just purely technical stuff?
There wasn't anything that we've discerned that said make a big change. It was really how well does it work? What do we do if mid-session our WebEx goes down? Is it okay to move it over to the telephone? That sort of glitch.
And we found that it is.
And we found that it is, so that's fine. So yeah, it was really on those first 5. It was technologic, and that's good news, right? We didn't have 100% completion.
That's great.
So
meaning they all followed through with the program.
Yeah. So that when you look across psychological treatments or behavioral health treatments, the gold standard is if you can keep 80 to 85% in, you've got a gold standard treatment, and we've got 100% so far.
That's great.
So that's pretty remarkable.
Another question here was about anonymity. What steps do you take to preserve anonymity? How do they know? Because one of the things you said, reluctance to treatment comes from they're afraid they're going to be,
So do you want to field that?
Yeah, treatment records are protected health information. So just like any other kind of protected health information, those confidentiality rules apply. There are a couple limits to that. We are mandated reporters, so if we hear about suicidal or homicidal intent, we would follow up on that. Abuse of a child or an elder or a handicapped person, we are mandated reporters for that.
It's a legal requirement.
Yeah, yeah. But treatment records, again, protected health information.
So it's just like seeing a therapist that you would go see. They can't reveal, or you since it is you can't reveal anyone's name or information.
No, I can't.
Or anything that could possibly identify them.
Right.
So we can't talk about towns or locations or anything that would potentially identify someone.
Awesome. So we have one. I think this will be our last text message question, unless you have one more. Last call out there. What is the term of the grant?
So we started in late July of 18. and we will wrap. No, I'm sorry. We will wrap up 17, and we will wrap up in August of 19.
Okay.
And chances are good, knock on wood, and the fates that control funding, that we'll be able to continue this. Our goal is to keep this program up and running in perpetuity.
Yeah, I mean, I think there's a need, at least ostensibly, for the, behavioral health in this fire service. So, you know,
Yes.
I understand why you would intend to keep it going as long as you can possibly do it. Why do firefighters refrain from recommending programs through their? Oh yeah, you were talking about on one of your slides. They won't take advantage of behavioral health services through their department or employee access programs. Why do you think that is?
Well, so one of the reasons is that sometimes, and again, this varies from place to place. Sometimes your EAP is a check mark, right? The city government is mandated to have an EAP program, and so they have one.
Right.
But that EAP program is a package program that comes from out of your district, that doesn't know any local providers, or that hasn't even generated a provider list. I called on behalf of a fire department. I called their EAP to vet their clinicians, and they didn't have any. Now that's one example, and there are other EAPs that are excellent and that are very fire-centric and are well thought of and used all the time. And then there are some that are in the middle.
Right.
A lot of times EAP is co-located with other leadership offices, and so then people think that their business leaks to the rest of the fire service.
Because if
telephone,
you're going, if your
telefirefighter,
person
that
is next
door
to
so
your supervisor, you might feel
Yeah.
a little reluctant to go walk into that office.
to go, yes, or if the person that you're in conflict with at work is seated in a waiting room next to you,
Right.
that can be really uncomfortable.
That makes sense. So this text message question, sort of reiterating, I think, how many patients so far? We said 14, right? Are currently in
Currently,
the. What are your average number of sessions? Yeah, that's an interesting question. Do they go weekly primarily, or are you seeing them basically weekly?
Yep, weekly.
Okay.
Yeah.
And this has been going on for, refresh my memory, the actual program after
Started in October. No, we started in September for access, the end of September.
I think a little bit earlier than that.
Okay.
Yeah, kind of late summer.
Late summer.
Yeah.
Okay.
And
And you still said you're maintaining 100%. What was the word?
retention.
Retention. I want to say
No
recidivism. but
Not yet.
That's not the right. That's not the right word.
No. So and the number of completers is small, but growing, right, with every week.
Sure.
And
And you're
then we have
accepting new
4 in the
patients.
queue that are coming on board
Okay.
right now. So we're anticipating that will continue to build.
Excellent. So last question, and yeah, this is something that I had a question about as well. So retirement, firefighters in retirement, because I know just from personal experience and just from talking to other firefighters just in the industry, a lot of the mental health issues set in when they leave the fire service. They're actually retired. Is this service open to retired firefighters?
I would say yes, but now I'm running through my IRB. But I believe retired firefighters are allowed, and certainly our intent is to include anyone who has chosen a career in fire service.
Sure.
So wherever in their career they are, even if they're in the retirement phase. In part, I'm devoted to that because that population is underserved and also at inflated risk of self-harm.
Yeah. Yeah, I just know from experience and just from what I've heard, a lot of I'm going to say guys, but that's not because there's a lot of female firefighters too. A lot of folks in the fire service, once they leave the fire service and they don't have that routine and they don't have the camaraderie and then that's when stuff starts hitting home that maybe was there during their service, but then it starts to become real apparent. I mean, you guys know, you've probably seen the numbers and the gory details, unfortunately. So.
Well, it is a high-risk time. And retirement's actually a high-risk time for all occupations,
Yeah,
right?
absolutely.
But it particularly in fire service where so much of an individual's identity is wrapped up in being a firefighter.
Yeah, that's what I've been trying to say, but you said it very well. And I know personally there's a lot of firefighters who, once they leave the fire service, their identity, they feel a crisis there. So, yeah, and that's good. Hopefully, if it's not available to firefighters or who have retired, maybe you could pilot a partner program or something available to them. Well, anyway, that's all the time we have. Thank you guys so much for being here. This has been really, really great.
Definitely our
It's been an incredible program to learn about Project Access, correct?